This is nursing management of the newborn at risk. So we're looking at acquired versus congenital disorder. So let's start by defining those. An acquired disorder occurs at or soon after birth. So this can be a problem or condition experienced by the mother, the woman, during pregnancy or during birth. Or sometimes there's no real identifiable cause for the disorder. A congenital disorder, the baby is born with it. It's present at birth, and it usually comes from a malformation that occurred during the pregnancy, so antepartal, and it's typically something from the genes, so it's inherited. And most of the time, there's the etiology, the cause is complex. It's not just a single gene or a single thing. So we're going to look at some different acquired conditions, and I've highlighted the ones we're going to look at. So respiratory distress syndrome, this is what happens to our preemies because they don't have enough surfactant in their lungs. Surfactant makes the lung tissue able to separate. It's like adding some water or soapy water when you're putting a vinyl cling on the window. That soap, that detergent, makes it not stick. That's the way surfactant acts. So it stops the alveoli from sticking together so that it takes less pressure to open them. So what do you see on this preterm baby who doesn't have enough surfactant? Well, they've got to work harder to open those alveoli. You're going to see expiratory grunting, and this is particularly at the end of expiration. So they inhale, exhale, inhale, exhale, It's a little grunt at the end. Nasal flaring, retractions, just sort of FYI, in the U.S. we call it retractions. Most other countries, including other English-speaking countries, call it indrawing. So it pulls in between the ribs. We call it retractions. Seesaw respirations. So the chest goes down as they inhale and out as they exhale. So it's kind of opposite of what it should be. Cyanosis. Often hands and feet stay a little cyanotic, but this is generalized, so all over. Heart rate above the 150 to 180. That's considered the upper limit of normal on our neonate. Fine respiratory crackles, right? That's that sound down there, that snap, crackle, pop, little crackly sound of the alveoli slamming shut and popping open. Tachypnea, up to 60 breaths per minute is normal on a neonate, so greater than 60. On the chest x-ray, you see hyperaeration, under expansion. So not all of the lung is open. What is has too much air in it, and they call it a ground glass pattern, where some is open and overinflated, where others is not open at all. So here's some things we're looking for as we look at that. Synchronized respirations as opposed to those seesaws. And here, if you notice, you can give a 0, a 1, or a 2, depending on what you hear or what you see. And it gives a nice quantitative score. So we're looking at the chest movement, the retractions or indrawing, xiphoid retractions, nares, nasal flaring, and grunting. So managing respiratory distress syndrome. Well, first is supportive care and close monitoring. We're probably going to have to do some respiratory interventions. We may be able to do CPAP, which is PEEP. If you're not familiar with that, continuous positive airway pressure, and really what we're worried about is the PEEP, positive end airway pressure. So at the end of exhalation, when you or I take a breath, we exhale. Intrathoracically and environment are basically the same atmospheric pressure, and then our diaphragm drops. We get negative intrathoracic pressure, which triggers us to suck in air. On this preterm baby, negative intrathoracic pressure makes all the alveoli slam shut rather than pulling in air. So by keeping that positive pressure, that end expiratory positive pressure, we prevent those alveoli from slamming shut. Exogenous surfactant, so we actually give them surfactant. Put down an ET tube, squirt in surfactant, and they probably will need some oxygen as well. Antibiotics, if there's positive cultures, correcting pH balance. We're worried about acidosis, respiratory acidosis. They're not able to exhale the CO2. Fluids and vasopressors, we need to keep them hydrated. Keeping the blood pressure stable can be a problem. We do need to give, these are infants, they need calories. They don't maintain blood sugar well, so we've got to keep some sugar going into them, either into the gut, gavage feeding, or into a vein through parenteral nutrition, TPN. Babies don't do well at maintaining their blood sugars if they're not getting very frequent feedings. So blood glucose monitoring, and they're working extra, right? That extra effort of breathing uses up glucose faster. Clustering care. We're going to do everything we need to do and then let the baby rest. And usually prone or side lying is the best position during while they have respiratory distress syndrome going on. And then supporting the parents and keeping them informed so they understand what's going on. And here's just some pictures of a baby with a nasal cannula and a baby who's intubated. So complications of respiratory distress syndrome. Well, air leak, we're trying to blow it with some pressure into the lungs. We can have problems with blowing a little too hard. Bronchopulmonary dysplasia, or BPD, is the old term. We now call it chronic lung disease, or CLD is what you'll see at the hospital. This means we did damage. We used enough pressure that we caused scar tissue in the lungs. Scar tissue does not go away. However, as the baby grows and makes new tissue, it becomes a smaller percent of the overall lung tissue. So hopefully over time, their respiratory issues get better, but they will have some chronic lung problems as they're growing. Patent ductus arteriosus, right? This is, if you remember the fetal circulation, this is that opening between the pulmonary artery and the aorta. In utero, blood is shunting to skip the lungs, so it's moving from the pulmonary arteries, and instead of going to the lungs, going over to the aorta and out to the body. Well, after birth, as the pressures change in your lungs, the pressures changes are one of the things that start that ductus arteriosus closing. If you don't change the pressures, that right side stays high because pushing blood into the lungs is hard because things didn't open the way they should. There's a big risk for that ductus arteriosus staying open. Congestive heart failure, again, we didn't change the pressures, and so you can get heart failure. Intraventricular hemorrhage, this is the ventricle in the brain where CSF is made, so that cerebral spinal fluid should be made in the ventricles. It comes out, bathes the brain, the spinal cord goes back and is absorbed at the same rate that it's made. The changing in pressure before the vessels are really mature, because it's a preterm baby, right? And the changing in oxygen, because in utero, a baby's at a little lower partial pressure of oxygen in the blood. So those changes make those fragile vessels around the ventricle of the brain rupture very easily, and you get bleeding in that area. And that, if you get that, that can lead to cerebral palsy, cognitive impairments, and hydrocephalus. You interfere with the normal pathway for the CSF to flow, and so it builds up. Retinopathy at prematurity. Excessive oxygen does damage to the retinas. So we actually want to turn down the oxygen as soon as we can on these babies so that we maintain their vision. And they often have catheters, so we're at risk of complications from central lines, infections, and thrombus. And then developmental delay or disability are a risk as well. So here's that interventricular hemorrhage, rupture of those capillaries in or around the ventricle of the brain. The babies who are at risk are under 1,500 grams or under 35 weeks of gestation. It's that immature vasculature and change in blood flow as well as change in pressure of oxygen. Complications: hydrocephalus, seizures, cerebral palsy, learning disabilities, vision and hearing deficits, cognitive impairment. We assess the anterior fontanelle. If it's getting full or tense, we have a problem. We're looking at the hematocrit, hemoglobin hematocrit, right? If a baby bleeds, a neonate doesn't have that much blood. So if you take a bunch of blood out of circulation, you're going to actually see a drop in the hemoglobin hematocrit. You're going to see their color is not going to pink up. Their perfusion is not going to be good. Perfusion, capillary refill, peripheral pulses, those things. Level of consciousness. Now I know a preterm infant sleeps a lot, but we're not going to see them have those cycles where they have some moments of being awake. It's going to interfere feeding, sucking. You'll hear nurses talk about a neuro cry. That's this high-pitched cry. It's a sign of some neuro damage going on. Necrotizing Enterocolitis, NEC. Again, this is a complication of prematurity, almost always. I guess some neonates can get it, but almost always going to be a preterm baby. So 3 things happen. You get ischemia of the bowel, so lack of oxygen. You get some bacteria inside there, and then that infection takes off, and so it affects feeding. So what you see is abdominal distension, and you can often feel bowel loops. So as you're palpating the abdomen, instead of it being soft all over, you feel loops. They may have bloody stool. They may have vomiting, particularly bilious, bile vomiting, and they're not going to tolerate feedings, especially if they had been tolerating feedings and now they stop. Necrotic bowel is dead. So you let that die, they will become septic. So you're going to see lethargy, apnea, shock. The way we look for it is a KUB, which is an abdominal x-ray. You're looking for air in the bowel wall and those dilated loops. Dead tissue has to be taken out. There's nothing we can do. So this child has to go to surgery and take it out. And so maintain fluid and nutritional status, right? We can't feed them, but they still need calories. They still need fluid. Bowel rest, so we're not going to put any feeding through there. We are going to give antibiotics because they will get septic, and IV fluids, and then the surgery. So the surgery, they take out the affected part of the intestine. We're usually talking about small intestine. So they'll do a temporary colostomy. They'll bring that up. They'll bring up the other end, and hopefully when everything's healed, they can re-anastomose, reconnect. So supportive care and education for the family. They're going to have to learn to take care of the colostomy or ostomy. And here's an infant with an ostomy. So birth trauma, you should have talked about these in OB, but just as a reminder, fractures, often clavicle fracture, that brachial plexus stretching, damaging the nerves, cranial nerve trauma, cephalohematoma, or caput. So swelling or a pocket of blood up on the head.